Well, thank you so much for coming on this rainy, dreary, ugly little day here in lovely Louisville. I just wanted to go ahead and welcome you all to the Dean's Visiting Scholar in Humanism series. We're going to be having Dr. Larry Mccullough, Dr. Lawrence B. Mccullough, actually go ahead and give us his talk today. Larry is Professor of Medicine and Medical Ethics in the Center for Medical Ethics and Health Policy, and Professor of Family and Community Medicine, and Faculty Associate of the Huffington Center down at the Baylor College of Medicine in Houston. Has been there since 1988. He's also the Associate Director for Education of the Center for Medical Ethics and Health Policy since this past December. Dr. Mccullough teaches in the Progressive Care Unit of Texas Children's Hospital in medicine and surgery and the services of the Michael DeBakey Veterans Affairs Medical Center and in Baylor's Departments of Pediatrics, Medicine, and Psychiatry. Dr. Mccullough has published more than 250 peer-reviewed articles and 10 books. He's published such things as Medical Ethics and Moral Responsibility of Physicians, the author of Ethics and in Obstetrics and Gynecology with Frank Chevernac, and Long-Term Decisions, Ethical and Conceptual Dimensions. He's also a Leibniz Scholar, to the enjoyment of Professor Wiggins here, and also wrote a definitive work on John Gregory's writings on medical ethics and philosophy of medicine recently, as well as surgical ethics. Dr. Mccullough received his A.B. in art history from Williams College and acts as a docent, still, I believe, at the Art Museum
when I can,
where he tortures small children, and has a PhD in philosophy from the University of Texas in Austin and held a postdoctoral fellowship at the Hastings Center. Most noteworthy for me personally is, if it were not for Dr. Lawrence B. Mccullough, I would never have entered the field of bioethics, where he drafted me and my first year of medical school at Georgetown University back in 1979. Dr. McCullough's talk today will be Bioethics, Historical Errors Concerning Truth-Telling and Medical Paternalism, Implications for Professional Medical Ethics. I give you Dr. McCullough.
Thank you. This is a very low-tech handout because most of this handout is, you'll see passages from what I now regard as the classical period of American bioethics, and then some contemporary bioethics. Then we're going to get into the real stuff from the 18th century, and then look at some of its implications. And so when you teach texts, you have to look at them. And my training is in the history of philosophy, and so I have a real passion for texts. I should tell you just two footnotes. One, the docenting at the Museum of Fine Arts in Houston is every third grader in the Houston Independent School District comes to the museum in the course of the school year. And what the teachers do is when they hear there's a male docent available that morning, and there aren't but about 3 of us, they find the 12 most misbehaved 12 third grade boys and give them to me. And there's this wonderful painting by Gérôme, the great French 19th century painter, in the collection of a tiger overlooking a desert on which 2 armies, little teeny tiny men, are lined up for battle. And I always ask the students, what do you think the tiger is thinking? And one day this one little guy said, lunch. And he's transformed my experience of that paint, because he's right. The tiger's sitting there in the sun waiting for lunch. And the other is, when I teach historical materials to my medical students, I always offer them extra credit if anybody knows from popular culture who Mr. Peabody is. Who's Mr. Peabody?
He's a really smart dog.
Correct. What kind of dog was he? A beagle. And he runs a machine called the Wayback Machine. So they go way back in time. Mr. Peabody, there's an episode that bears directly on bioethics and provides a complete refutation of the work of my colleague and dear friend Tris Engelhardt. Mr. Peabody has a pet boy named Sherman who goes with him on these trips. And in one of the episodes, Mr. Peabody is petitioning the court to adopt Sherman. And the opposing counsel asks him, Mr. Peabody, you're a beagle, aren't you? And Mr. Peabody says, yes. And he says, that means you're not a person. To which Mr. Peabody says, another point in my favor. Those of you who own beagles will know what I'm talking about. So we're going to get in the Wayback Machine and travel first to the 1970s, then back up to the present, then back to the 1770s. And there's a lot at stake in this, because the major theme I want to suggest to you is that bioethics has deprofessionalized medical ethics to a great extent, and as a consequence has left clinicians disarmed for dealing with major problems. Now, I should add immediately, at our medical school, we do not teach bioethics. We teach professional medical ethics in the curriculum. But in a lot of philosophy departments and in medical schools, bioethics is being taught. So this is not a benign fight over words. It's a real fight over how to conceptualize the work. Here's how the field started back in the 1960s and 70s. This is Roman 1, is that there was an assumption that physicians were silent with their patients in the past and did not give them information about their conditions, especially serious diagnoses, and especially life-taking conditions. Not life-threatening, life-taking. And also, physicians did not involve their patients in decision-making about their medical care, and physicians were therefore systematic paternalists. When I first went to work in this field back in 1974, this is what I was taught, and what indeed, when I began teaching in 1976, I myself taught. Here's a canonical text to support the claim. This is from Bob Veitch's very important book, Death, Dying, and the Biological Revolution. Physicians are strongly committed, in the ideal at least, to protect patients from potential harm, both physical and mental. According to one important study, 88% of physicians responded and reported they follow a policy of usually not telling patients they have cancer. Now, that's from a very important article by Oken, which we're going to look at more closely in a minute, because it's been completely misinterpreted. Some of these physicians may have decided not to tell for irresponsible reasons. To tell someone he is about to die is not a pleasant task and can be time-consuming. It turns out that's the reason doctors didn't do it, and it's not irresponsible at all. It's quite understandable, and I'll get to that as well. But physicians, for the most part, are morally dedicated to the principle of judiciously withholding information that they feel would do serious harm to the patient. To transmit it would violate their medical moral responsibility to do what they consider to be in the best interests of their patient. The Hippocratic Oath has the physician pledge to follow that regimen which, according to my ability and judgment, I will consider for the benefit of my patients and abstain from what is deleterious and mischievous, which is not a good translation of the oath, but not a bad one. Bernard Meyer, from a 1968 article, a physician who has written on the ethics of what should be told to the terminal patient, says, "Ours is a profession which traditionally has been guided by a precept that transcends the virtue of uttering truth for its own sake, that is, so far as possible, do no harm." And that's just wrong, but we all believed it back in the 1970s. It was commonplace for textbook collections to transmit this view, and here I cite the one from which I taught in a brand new course in medical ethics at Texas A&M University. My colleague will be interested to learn that when the course was proposed, the English department rose up against it at the liberal arts faculty meeting, calling it cheap hucksterism and pandering to the pre-meds. That's because they taught a course on technical writing and didn't want to lose the pre-meds to the philosophy department. But this was a matter of principle. Well, it was in Texas. University budgets in the state system in Texas are driven by enrollment, so it was a matter of principle. It's called money. And this was back before Texas allowed for concealed firearms, so it was still safe to attend faculty meetings. Now we have the big warnings, do not bring these into buildings. Although you can now ride the Houston Metro Rail with your concealed firearm, thus making your fellow citizens feel much safer. There was an important analogy made to state laws about motorcycle helmets and their use. Of course, if you work in the transplant community, which I do every now and then, you know you want those helmets off because you want the patient freshly brain dead. It would be good if they were wearing chest armor so the internal organs of the thorax and abdomen are preserved from serious trauma, but you do want them freshly dead. But back then, legislators were making people wearing helmets. But the argument was this: the legislature is incompetent to determine my interest, because Americans all believe that, except in a few areas, the government is incompetent to determine what's in my best interest. And that becomes very important, because it gets argued against physicians, that they are incompetent to determine what's in their patients' health-related interests. And there's the deep professionalization. That's where it occurs. So this analogy was not innocent, but everybody treated it, including myself. Here's the passage on paternalism from the Encyclopedia of Bioethics in 1978 by Tom Beecham, who is arguably then and now the world's authority on this subject. One of the more obvious instances of paternalism in medicine is the wide range of cases where doctors and families believe that it is in a person's best interest not to be told of a particularly bad diagnosis or prognosis. And then maybe the most influential text at all is Jay Katz's The Silent World of Doctor and Patient. Just a short passage from the introductory section of that book. The history of the physician-patient relationship from ancient times to the present bears testimony to physicians' caring dedication to their patients' physical welfare. Probably that's not true either. But here's the key thing: the same history, by its account of the silence that has pervaded this relationship, also bears testimony to physicians' inattention to their patients' right and need to make their own decisions. Little appreciation of discourse and consent can be discerned in this history, except negatively in the emphasis on patients' incapacities to apprehend the mysteries of medicine and therefore to share the burdens of decisions with their doctors. And this was, until we've had much better scholarship in the history of medical ethics and the history of medicine in recent years, what everybody believed. Let me just pause for a moment and look at the Okun article, because this gets cited frequently. This was an article that appeared way back in 1961. And Okun is the first one to acknowledge that at that time, when patients were told cancer, they were essentially told they were going to die from their cancer. It was a death sentence. We would now call this a convenience sample of 219 physicians in his own hospital. So this was not a representative sample, nor does Okun present it as one. He's quite circumspect in how he presents this. He has a 95% response rate, which is outstanding, so you can be confident the data represent his sample. His sample, however, represents only itself. Now, what's cited is the 88% who say they have their usual policy of not telling patients. But what's not cited: 32% make exceptions, often or occasionally, 47% very rarely, only 8% never tell. Those are the paternalists, and they're a distinct minority. Notice the next thing. Agreement was essentially unanimous. He asked this question, that some family member must be informed. Now, if you're a paternalist, no one should inform the patient. Because if it's bad for the patient to know they're seriously ill, the issue is not who's telling them. The issue is the information itself. By the way, this turns out to be the most common strategy by which patients were indeed told. These doctors, I don't think, knew that, but they were unwittingly inheriting a centuries-old tradition. Okun goes on to challenge the assumption that cancer patients cannot bear this bad news. And then he makes a very important point. Not telling cancer patients their diagnoses may be self-protective. There is a strong tendency, he writes, quote, to avoid looking at the subject of cancer and the facts related to it. And then the next one is how doctors turn away from this. Without realizing it, he puts his finger right on the heart of the topic. This is the historical argument that is given. Doctors shouldn't tell patients because it's really hard for doctors to do this. It's a self-protective policy. It's not a paternalistic policy at all, and I'll give you textual proof for that shortly. Just to show you how this still shows up in the contemporary literature, in Bob Veitch's latest work, his very nice little book, The Basics of Bioethics, he again cites this and points out toward the end of that little quote, they were afraid that if they told the patient would become psychologically upset. And the Hippocratic Oath says not to do things that will upset the patient. That's not true. The oath itself is silent on this topic. It's in decorum. And what decorum has is a whole section on how you should interact with the patient. For example, prepare your prescriptions in another room so the patient cannot see what you are doing. Why? Was there an FDA? No. Was there a Bureau of Narcotics and Dangerous Drugs regulating controlled substances? No. What was the theory of health and disease of Hippocratic? Every health and disease was a disorder of diet and exercise. What were you preparing? Diet. What were you preparing it from? Household foods. Why do you want the patient not to see you doing it? Because then they'll copy you and fire you and you won't make any money. These guys were entrepreneurs. This is all guidance on how to protect the trade secrets so you protect your market share in a no-holds, unregulated market in which if you did not succeed, you didn't have an income. Right? Your mind would be focused. When it gets to the section of what it tells the patient, it says don't tell the patient the patient's diagnosis. Experience teaches that many patients have an adverse reaction to this. So they cite data, but they don't interpret the data. If they have an adverse reaction to being told bad news by their doctor, who are they going to blame? The doctor. Who are they going to fire? The doctor. It's as much self-protective as it is paternalistic, but the point is it's not interpreted in the text. I think the context, and many other scholars who have looked at it, is the context is the Hippocratic physicians were entrepreneurs. They were not professionals. We have to disabuse ourselves that the Hippocratic texts give us professional ethics. They really don't. And here I rely on work like people like Vivian Nutten in London, who's a great scholar of these texts. It's just not there. So Bob gets it wrong. In the 5th edition, the gray version, as my students call it, of the Principles of Biomedical Ethics, I assume there will be a 6th version before too long. It's been almost 4 years now. And what color it will be, I don't know. I would prefer chartreuse myself, but those in the medical world know that journals go by their colors, so we should have medical ethics books go by their colors as well. But here's what they write: throughout the history of medical ethics, both the principle of non-maleficence and beneficence have provided the basis for paternalistic action toward patients. For example, physicians have traditionally taken the view that disclosing certain forms of information can cause harm to the patients under their care, and that medical ethics obliges them not to cause such harm. The first part is true, the second part isn't. So let's look at the text. I'm going to rely on 2 major historical figures who really write the first modern medical ethics, and that's John Gregory in Scotland and Thomas Percival in England. Gregory's book appears in 1772, is brought immediately to America by Benjamin Rush and his other students, and within 20 years is translated into French, German, Italian, and Spanish, which are all the major European continental languages. The history of his influence on subsequent European medical ethics is just being written. But it's pretty clear to me that the virtue-oriented medical ethics of Spain and Italy to this day actually originates in Scotland. And it's fun to tell colleagues from those countries, you know, you practice Scottish medical ethics. And then they think for a minute and say, as long as it's not English, that's okay. And I agree, of course, absolutely. So here is what Gregory writes, because he takes these topics up. A physician is often at a loss in speaking to his patients of their real situation when it is dangerous. A deviation from truth is sometimes, in this case, both justifiable and necessary. It often happens that a person is extremely ill, but yet may recover if he be not informed of his danger. Now, he thinks he's citing clinical evidence. So he thinks scientific evidence to support him. It sometimes happens, on the other hand, that a man is seized with a dangerous illness who has made no settlement of his affairs. The gender-specific pronouns here are deliberate, and yet perhaps the future happiness of his family may depend upon his making such a settlement. I mean, if you have an estate and die without a will then and now, this is a calamity for your heirs. In this and other similar cases, it may be proper for a physician, in the most prudent and gentle manner. Prudence is the virtue of self-protection. Gentle is the virtue of dealing with patients. To give a hint to the patient of his real danger and even solicit him to set about his necessary duty. But in every case, no exceptions, it behooves a physician never to conceal the real situation of the patient from the relations. So tell the family they will do this unpleasant work. Indeed, justice demands this, as it gives them an opportunity of calling for further assistance if they should think it necessary. That's the clergy. Gregory reverses a 2,000-year tradition in medicine of physicians declaring the dying incurable and withdrawing so that the mortality would not be on their hands but on the disease's hands, and then leaving them to the care of clergy. And he actually has an ethics of the interaction of doctors with clergy at the bedsides of the dying. To a man of compassionate and feeling heart, there's the language of David Hume, this is one of the most disagreeable duties in his profession, but it is indispensable. The manner of doing it requires equal prudence and humanity. That is, legitimate protection of self-interest on the one hand, and humanity or sympathy, those are words interchangeable for the central principle of Hume's moral philosophy. What should reconcile him the more easily to this painful office is the reflection that if the patient should recover, it will prove a joyful disappointment to his friends, and if he die, it makes the shock, that is for his friends, more gentle. So if you do it, if you make sure that it's done, it's a no-lose proposition for the survivors. So Gregory is not a paternalist here. The argument is not this is bad for patients, therefore we should not do it, and we should interfere with their autonomy. It's rather it's bad for us, so let's get the family to do it. Remember, he is one of the first doctors to stay with the dying and to establish that as a moral standard. The Hippocratic texts say you should declare the dying incurable and withdraw out of self-interest, and that becomes the standard up until Gregory's time. He reverses, as I said, 2,000 years of medical ethics. That's one heck of an accomplishment. If that were his only accomplishment, it would be extraordinary, but he changed everything. Now, from Percival. Percival is talking about patients in the infirmary in Manchester. The infirmaries, or if they were royally chartered, the royal infirmaries, were hospitals for the working sick poor to be cared for free. The hospitals were paid on an annual subscription by their employers. This was the first direct single-payer system, actually a multi-payer system for a designated population of patients. Here's what Percival writes: "It is one of the circumstances which softens the lot of the poor, that they are exempt from the solicitudes attendant on the disposal of property." Solicitudes by Mark and his colleagues, who would be petitioning them for business. Yet there are exceptions to this observation, and it may be necessary that an hospital patient on the bed of sickness and death should be reminded by some friendly monitor. Who is this? Wait till you hear what he says. It's marvelous. By the way, remember, the hierarchy of the forms of life in the infirmaries in Great Britain were physicians, apothecaries, female midwives, then the scurrilous surgeons. Okay? Surgeons almost didn't know what they were doing, and you brought them in only to amputate in hopeless cases, and you knew what the outcome was going to be. There would be an amputation followed by infection and death. Surgery has improved since then, I understand. And it may be necessary, fill out a last will and testament to his wife, children, relatives, otherwise might be deprived of his effects of his expected prize money. So sailors were cared for here. When you captured an enemy ship, it was sold. And depending on your rank on the ship, you would get a share of the prize. Or some future residual legacy, that is from your own parents. This kind of office will best be performed by the house surgeon. Right? The lowest form of life. If there were medical students there regularly, it would have been assigned to them. But there were medical students, but they weren't there regularly. And by the way, medical students had to buy tickets to give to their professors to come on rounds, because that's how their professors would get paid. Whose frequent attendance on the sick diminishes their reserves. That is, diminishes that unease of dealing with the dying and entitles them to their familiar confidence. And he will doubtless regard the performance of it as a duty. Right? He'll become indoctrinated in it. For whatever is right to be done and cannot be by another, we physicians, right, so well done, because we'll be too upset to do it, has the full force of moral and personal obligation. Isn't that marvelous? It's just terrific. He goes on to talk about private practice. A physician should not be forward to make gloomy prognostications because they savor of empiricism by magnifying the importance of his services in the treatment or cure of the disease. This one got completely misinterpreted. This is about crepe hanging, very common practice where you say to the patient, your situation is very serious. I'm not sure we're going to be able to pull you through, but we're going to do our best, knowing all the while that the patient's condition is not that serious, and the treatment you're proposing, especially in surgery, is likely to be successful. This remains a problem in contemporary surgery, by the way. My colleague Jim Jones, with whom I work on ethics in surgery, has called this a corrupt practice in print with me. I said, "You sure you want to use that word, Jim?" And he said, "Hell yes." So we did. Someone from Oklahoma, especially, who lives an entire life in Texas, as a sensible person should, who's born in Oklahoma, says, "Hell yes," then you do it. But he should not fail on proper occasions to give the friends of the patient timely notice of the danger when it really occurs, and even to the patient if absolutely necessary. So you see that same avoidance behavior you saw in Gregory. This office, however, is so peculiarly alarming, that is to the physician, when executed by him, the physician, that it ought to be declined whenever it can be assigned to any other person of sufficient judgment and delicacy, that is some member of the household or a wise and judicious, usually male friend, I would think. For the physician should be the minister of hope and comfort to the sick, that by such cordials to the drooping spirit he may smooth the bed of death. Right? By the way, how did you do that in 1803? What medication would you use, widely available? Laudanum, very effective painkiller, and sedative. Revive expiring life and counteract the depressing influence of those maladies which rob the philosopher of fortitude and the Christian of consolation. The order of that, by the way, is not an accident. This was a self-conscious major figure of the English Enlightenment who was himself a Unitarian, right, and saw his church burned to the ground by an angry Christian mob when he was a young man. So those Christians are over there. We Unitarians, of course, know the truth about the fact that the incarnation is a pernicious and false belief, but we won't get into that. Physicians were not paternalists. Here's what Gregory says. The governance of a physician, that is how much control you should try to assert, should undoubtedly be great. But then he gives a completely practical argument. But an absolute government very few patients will submit to. A prudent physician, therefore, should prescribe such laws as, though not the best, are yet the best that will be observed. Of different evils, he should choose the least, and at no rate lose the confidence of his patient so as to be deceived by him as to his true situation. This indulgence over which I am pleading for must be managed with judgment and discretion, as it is very necessary that a physician should support a proper dignity and authority with his patients for their sake as well as his own. But notice the next passage in C. Every man has a right to speak where his life and health is concerned. This is not a silent world. It's not a paternalistic world. And every man may suggest what he thinks may tend to the life of his friends. So Gregory says he's a good Baconian. You've got to be open to remedies and theories of explanation of disease and health wherever they're coming from. He was well aware of the decrepit state of the science of medicine in his own day and bemoans that. Note what he says. It becomes them, that is patients, to interpose with politeness and a deference to the judgment of the physician. It becomes him to hear what they have to say with attention and to examine it with candor. That's a Baconian virtue that means, as odd as this sounds, it could be right. The evidence may support it. I have to listen. I could be open to instruction here. If he really approves, he should frankly own it and act accordingly, that is, do what the patient wants. If he disapproves, he should declare his disapprobation in such a manner as shows it proceeds from conviction, that is, the evidence, and not from pique or obstinacy, a problem that still occurs in contemporary practice of medicine. If a patient is determined to try an improper or dangerous medicine, a physician should refuse his sanction, but he has no right to complain of his advice not being followed. This is an excellent ethics for dealing with patients who practice what's called alternative medicine. Right? It was good in the 18th century. I think it's pretty good now. Now, was there a practice of consent before we think it was invented by the courts in the early 20th century in the United States? And it turns out recent scholarship shows, yes, there was, long predating Schlondorf. Andrew Ware is a wonderful historian of medicine and a great man, and a Scot at the Wellcome Institute in London, and has written a beautiful work showing that as early as the 17th century, English surgeons got consent from their patients for surgery. One of the reasons was to draw a contract with the patient specifying the surgeon's duties and the patient's duties, as a good contract should, and it was done to protect surgeons from bad outcomes that were owed to patients' non-compliance. So the motive may not have been one of respect for autonomy completely, but there was a practice of consent. And in a remarkable piece, Kathy Powderly at SUNY Downstate in Brooklyn has gone to the work of Alexander Skane, a surgical gynecologist in Brooklyn in the 19th century. All female patients. So get ready for a counterintuitive experience. He had a practice of consent. He had a practice of offering and recommending surgeries. When they were very mutilating of the women, he was willing to accept their refusals and negotiate them, including trials of non-surgical management with female patients in 19th century America. Just a remarkable, it just doesn't fit all our models of the history of medicine. So what are the conclusions from this? Is that bioethics predicated itself on major historical errors. I don't blame them for not realizing they were errors then. I don't think we had the scholarship that we've gotten, especially in the last 15 or 20 years. Remember, we're talking about the 60s and 70s, it's a long time ago. So the first mistake, physicians were usually silent or were not honest with their patients for the benefit of their patients. Physicians did not involve patients in decisions, and so they were systematic paternalists or just paternalists. And instead, physicians were not forthcoming with bad news because it's disagreeable to do it. It still is. I think at your medical school and mine, we have to teach our students how to do this so they deal with their responses to giving bad news. We've made progress from when I was teaching at Georgetown, when the physician David knows Milton Korn, then the chief of medicine, stopped me in the hall one day and said he had an ethical problem, and he wanted to know if it was okay to take a resident out behind the building and have him face a firing squad for doing the following. The resident walked into the room of a 47-year-old man who had just been diagnosed with pancreatic cancer. This is the early 80s, so the surgical procedures had not been developed that we have now, even with all their mortality. And said to the patient, "You have pancreatic cancer. We expect you to be dead in 6 months. Here's 5 reprints from the literature," and walked out. So I said to Milton, I said, "Firing squad might be a little too strong." He said, "How about a firing squad with blanks?" And I said, "Yeah, that would give the resident an experience of what he just put the patient through." Then I said to Milton, I said, "Do you teach your residents how to give bad news?" And he sat for a minute, stood for a minute, and said, "No." And I said, "Well, what do you expect?" He copied one of the attendings. And Milton said, "I think I know which one." And it was around that time that people began to realize, no wonder there's such a bad job being done. They're not being taught how to do it. And many physicians didn't do it because we train doctors correctly that if you don't know how to do something and you might do it badly, don't do it at all. Right? Let it, get someone else who knows how to do it, i.e. the chaplain, but don't do it because you could make things worse. Physicians did involve patients, if Weir is right, as early as the 17th century, and Kathy Powderly's evidence is absolutely overwhelming as early as the 19th century. And so physicians were not paternalists or systematic paternalists. So what are the implications of this? I think medical ethics has been, in the field of bioethics, deprofessionalized. Why is this important? It's really 2 and 3 on this list. There is a major problem in contemporary medicine of patients or their families asking that everything be done at the end of life. The reasons they're making these requests are complicated. I think they have to do with the history of, especially of people of color, of a history of undertreatment in the past. In systems like the VA or our county hospital in Houston, there's a long history of distrust that they know, veterans all know that everything they've gotten they've had to fight for. Mr. Bush is at it again, so they're going to have to fight again. I mean, this history keeps repeating itself in the VA system. But if there's no professional ethics, that if there's nothing physicians can stand on as a claim to intellectual authority for their judgments, then physicians are left and nurses are left disarmed in the face of these requests. They feel they have to go along. And also with the advent of managed care and now its successors and increasingly strong managers in the clinical setting, it left physicians disarmed in the face of growing organizational power, which is wielded by their fellow physicians who are in leadership positions and lay managers. And the really radical claim is in 1B above, and that is that the claim of physicians to intellectual authority about their clinical judgments about patients' health-related interests are regarded in contemporary bioethics as suspect. Bob Veach is explicit about this. At least one of the refreshing things about reading Bob's work, my former colleague at Georgetown, with whom I argued cats and dogs for 8 straight years and didn't make any progress. Neither did he, so they always made it fun. But he takes the view that there really is no reliable science under medicine, that it's all wobbly and unreliable, and therefore lay people's judgments is just as good as clinical judgment. Clinicians in the room are furrowing their brows. You should. This is classic postmodern thinking. Medicine is a decidedly Enlightenment modern enterprise and should not give that up for a minute, because then we'll revert to the pre-Gregorian day of entrepreneurial medicine where it was all just wide open. So what we get from the history of medical ethics is what we need, and this is at the top of page 8, is from Gregory and Percival is a concept of medicine as a profession, which is not the sociological concept, which from the point of view of medical ethics is really quite anemic. It doesn't have to do with how you're institutionalized and whether you get to pick your patients and whether you are paid by patients or paid a salary. That's not relevant. The core concept is, first, that physicians ought to know what they're doing. They ought to be intellectually and clinically competent, and for Gregory and Percival that meant Baconian scientific medicine, and each of them had a nascent concept of what we now call evidence-based medicine. Second, physicians should use their competence primarily to benefit the sick and not advance their own self-interest. And third, they should maintain medicine as a profession, as a public trust, not a private guild, which up until then it largely had been. For them, medical ethics is not conservative. It is a radical reforming enterprise. It's interesting, the historians of medicine have labeled this conservative. It's not. It's not preserving the status quo. It's a direct attack on the status quo, which I think makes it especially interesting. But what does this mean for consent at 7 at the bottom? It means that in the consent process, the role of the physician is to use his or her intellectual authority to identify the clinically reasonable alternatives, i.e. those that have some evidence base that they will either maintain current health status or improve it. Now what's interesting is in the law of informed consent, this is exactly what the courts say. They describe this as a fiduciary duty, which I think is very interesting. So the law got it right from the beginning, as near as I can tell, in the classic cases. But the crucial distinction is medically reasonable is not technically possible. See, if you think you have no authority and patients and their families' judgments are just as good as yours, then you don't make this distinction. So you say, well, if your dad arrests, would you like us to stick a tube down his throat and put him in the intensive care unit? And the family thinking, well, we don't want dad to die, say yes. And I asked my residents, well, do you think that would have changed the outcome? And they say no. I said, well, then why'd you offer intubation? Because I have to, don't I? So we have a generation of residents who have absorbed the postmodern understanding of themselves that they have no intellectual authority in matters of health. Now, that by the way, that's all doctors have intellectual authority in. Where they get themselves in trouble is thinking they can speak with authority outside matters of human health. And they generalize their expertise. As we know, that gets you in trouble. So patient surrogates then pick from among these, and that's what should be done. Yes, sir?
We'll wait till we're done.
Okay. We're almost done. So what we get from this is the concept of the physician as a professional, or the ethical concept of the physician as a fiduciary, someone who is worthy of intellectual and moral trust. We can extend this to healthcare organizations. This helps us deal with their power. Healthcare organizations are co-fiduciaries. Their leadership is expecting physicians to be economically disciplined. That's a perfectly reasonable request, since the payers are turning the screws very hard on hospitals and delivery groups to control their costs. But the way you do it is to deliver the highest quality medicine, because the least expensive patient is the healthiest one at the end of a process of care, not one on whom you have reduced the component of the process of care to its lowest cost. To give you an example, at our VA in Houston, by 4 years ago, the budget for the formulary had doubled up to $56 million in the space of 5 years, and they were in danger of dislocating the whole hospital budget. So they assigned a physician to monitor the use of expensive prescriptions in the hospital. And he would fight with the doctors. You had to basically have a duel in the hall. That's where the concealed firearms came in. And you would duke it out to get to use these expensive antibiotics and the like to treat your patients. Nobody was looking at, gee, if I use the cheaper one and the patient's discharged but gets sicker faster and comes right back in for an unnecessary next admission, what will we have spent on that far outweighs the cost of what we would have spent on the more expensive drug? That kind of thinking didn't occur. When you're looking at piecemeal cost of component control, which is what managed care did until light dawned on Marblehead and quality began to take over. But this is the language you need, because if you're told to cut costs and the person has power and you don't think they have any ethics to guide their power, you're left helpless as a clinician. Instead, the language of fiduciary professionalism says, look, you share responsibility with me, so you're held to the same standard. I will be economically efficient, but I'm going to do it by being an excellent doctor. Let's see if this will save money in the long run. It looks like it does, by the way. I mean, there's a lot of that. For example, there's studies that I've looked at. I'm not an expert in this, rely on those who are, that disease management protocols for diabetes can deliver up to 25% savings within a year. And it's simply by having more rigorous controls over diet and everything else, and working with patients to control their blood sugars. And then the final thing to remember is that, and here the appeal to this unbroken tradition from Hippocrates becomes very important. Professionalism in medicine is a very young idea, and it has not been fully instantiated by physicians. There are a lot of doctors these days who are entrepreneurs. They're in my medical school, they're in your medical school. They behave themselves around me because I'm the ethics professor, and they know I'll scold them. But they don't behave around other folks. And David Rothman did us all a service in his article in New England Journal in 2000, where he showed just how weak the state of professionalism in medicine is. The reason this is important is if it were an ancient idea, 2,000 years old, it would be a lot more durable. When an idea has been around that long, if a few people defect from its practice, the idea itself has such historical flow behind it that that defection doesn't cause as much injury as when there's defection from a much younger idea. The example I use with my students is, if tomorrow morning 500,000 Christians tomorrow became atheists in the United States, monotheism would not be affected as an idea. If 10 million Americans became atheists tomorrow morning, monotheism as a global idea would not be affected. Take it up to 100 million, it still wouldn't be. You're talking about 1 billion or more people. This is a vivid, strong, long-standing tradition that historical momentum helps to carry it. Not with professionalism in medicine. It's very young, and it's got to be self-consciously taught and sustained by our students. And so in recent years, we've actually made this core concept at the top of page 8 the core of our curriculum in ethics at Baylor. They get this in the opening lecture. I happen to know because I give it, so that we explain to them that we are not doing all this exciting, sexy stuff about stem cells, but we're teaching professional ethics. And if we talk about stem cell research, it's going to be done in that context. So it's a plea really to be wary of medical ethics as bioethics. That is not an innocent classification, because it deprofessionalizes medical ethics, I think, in a way that has been very deleterious to the profession of medicine. I can't speak to nursing, I don't know it well enough, but my hypothesis would be the risk is there as well, and that we need to recover this way of thinking from these two great physician philosophers of the 18th century. With that, I'll see what questions you all have.
Thank you. Let's open it up for questions. Rob?
Yeah, I have a question and a comment. I'll give the comment first. In your example about the DNR, there's another contextual component in that the hospitals have a default position that all patients will be coded unless there is a DNR order.
Right.
And so to offer a DNR is to make an attempt to change the default, because if you don't do that, there are other conflicts, that come up that are ethical, in nature. My issue comes up to, when I assess the situation to be futile, to offer a DNR, if the patient refuses a DNR, which I expect will be futile, then I become in conflict. But, there's nothing else to do, according to my understanding of the situation, based on the organizational default. So this is just a comment that it's not necessarily a physician, writing a DNR.
That's true.
As the ethical issue. There's the organizational ethics that, kind of determines what we do.
I agree. Now, here's the...
Larry, just summarize in your mind, because I don't know if that's going to pick up for our videotape.
Well, the question is that isn't the discussion of DNR in the context that that's the default position, unless there's an order to the contrary, and the answer is yes. And then when issues of futility of resuscitation arise, if the patient doesn't agree, you're left in a bind. Now, bioethics analyzes the bind as a conflict between the principles of beneficence and respect for autonomy, and says that if you write an order unilaterally, you have interfered with the patient's autonomy and you're a paternalist. The analysis leaves out that resuscitating that patient will be seen by the team as crazy. Now, that's a placeholder for my professional integrity is now being damaged by doing this. Now, there's nothing in the ethics of autonomy in the canonical text like Beecham and Childress that says that patients have a right to exercise their autonomy at the price of serious injury to professional integrity. That's the professional ethics argument. It would change the dynamic completely, because then it would say to hospital administrators, wait a minute, if the futility is being invoked because this would be a violation of professional integrity to resuscitate this patient, or to keep a patient with multi-organ failure syndrome in the ICU, when the Society for Critical Care Medicine said that's the one diagnosis that should get you out unilaterally, because it's not only not going to do any good, we're just going to load morbidity on until you die with no offsetting benefit. Now, it turns out that when Texas revised its Advanced Directives Act, our legislature bought that argument, and we have a futility policy in our Advanced Directives Act. So if you were in Texas, you could call an ethics consult and start a process to try to override that. And at St. Luke's, where I run the ethics consult service, we've had 5 of these cases reach the full committee, because we've been able to negotiate most of them at the bedside. But in all 5 cases, the committee upheld the attending. When that was communicated to the families, with one exception, they all changed their minds. Very interesting question about the ethics of organizational power, backed up by the law in that circumstance. The VA, by the way, has a futility policy. A lot of folks in the VA system don't know that, but there is one. And so you can set limits in the VA and go through the same kind of review. And what it's premised on is our physicians and nurses cannot be forced to do something out of respect for autonomy that violates their professional integrity. So the bioethics analysis would leave out what's motivating the resistance, and when you look at it from the point of view of professional ethics, it's correctly motivating the resistance. See, the analysis really is, I have a positive right to oblige you, my clinician, to act in a way that violates your professional integrity. That's not what respect, that's a weak concept of autonomy. The strong concept of autonomy is, I have a right to be left alone to make my own decisions. But if I refuse DNR status and stay your patient, I'm not leaving the hospital. I'm still your patient. So now I'm obliging you to carry out treatment that you think is not acceptable ethically. That analysis never gets into the bioethics account. It doesn't get into issues about coerced cesarean intrapartum. The bioethics analysis misses the professional integrity component of that analysis altogether. So there you can see the real sharp difference between the two ways of thinking. That bioethics looks for paternalism as the enemy, asserts autonomy as the solution to it. Professional ethics says, no, it's much more complicated than that. And if professional integrity is at stake, then maybe we don't have to do this. You have to think through the ethics of going that way, because there are real issues of power being asserted. So that would be my response to that. That the organization, in other words, you should work on an organizational policy that invokes futility, and my colleagues in Houston actually published one in JAMA back in 95 or 6, was it, Mark? And the plan was to have it, to look for a test case in one of the medical center hospitals and then take it to court to go all the way to the Supreme Court in Austin. The hospital leadership agreed to this. They said, yeah, you get us a good test case, we'd like to do this. Because they were listening to their doctors who were really upset. But then for complicated reasons, the Advanced Directives Act got rewritten in 1999 and the issue became moot. But they looked at that policy and put it into the statute for just...
From an action point of view, myself as a physician, care provider, all the possible actions I can think of are very time-consuming. I can offer the patient that I don't agree with their decision, to DNR when I consider it to be futile, that they can get another doctor, that I can go to administration and try to get an ally, or I can go to an ethics committee, which I've been told, often takes a lot of time for response and then consultation. The issue of, the business of medicine, making money, seeing other patients, going to clinic, doing other things, and the conflict of investing a lot of time when there's the potential of, litigation or disciplinary actions, it doesn't make a lot of sense.
Right, to deal with all that, you need a strong organizational policy where the leadership of the hospital says, including litigation, we will stand behind you if you follow this policy. At our hospitals, you can get an ethics consult, and it comes within 24 hours. If the review process starts, the ethics committee can't meet earlier than 48 hours unless the family agrees to, and we've done it as quick as 24 hours, and it's done at that meeting. So you have an answer right away. So we have set up policies and practices that move it much more quickly. We did have one case where the family was told that the treatment would be stopped, and the law says there's a 10-day clock that starts. And the wife went to court to get a temporary injunction against the hospital not to start that 10-day clock. The hospital pulled out the stops. The hospital's external counsel worked through the night preparing the pleading, and they won. The judge issued the DNR order from the bench. So that case at St. Luke's had a big impact because it said to the professional staff, the hospital will stand behind you if you follow hospital policy. If I think I'm in an organization whose policies aren't going to support me, I know what I'm going to do. I'm going to protect myself. I'm no fool. But see, that undermines professional integrity as soon as you have people thinking that way. So organizational policy and culture become absolutely crucial.
That's a good point, and one to which we've not yet progressed here, but we do have an organizational policy at U of L Hospital for futility that works through a committee appointed by the Hospital Ethics Committee in the event of such a dispute. The second level in which futility is operative is kind of in the ethos at U of L Hospital, which is the old general hospital, kind of takes all patients. But those physicians handle it in terms of suggesting another physician or another hospital to treat them beyond what they're willing to do. So that is another tier. We have not yet tried the procedure that's outlined in the policy, but it has been approved. It has not gotten to the legislative level either.
Is the hospital willing to litigate it if it has to?
Again, summarize.
Good question.
Oh, the question is, the U of L hospital has a policy on futility, but it's not really been tried out yet. Is that the fair summary? And that physicians use basically an avoidance strategy. That's questionable these days. In one of our hospitals, there is one physician where the way we deal with these cases, because he won't kill anyone, that's his phrase, is we persuade him to transfer the care to one of his colleagues in his group, who then kills the patient. We say, look, the law is against you, ethics is against you, your own specialties. Ethics literature is against you. He says, I don't care, I'm not going to kill patients. And he says that to their family. He says, what do you want me to do, kill them? So it takes a couple of days to get those problems unraveled. But the hospital, when it promulgates a policy, has to then tell the professional staff of the hospital, we will back you all the way if you follow this policy. If we have to go to court, we will go to court. And if necessary, the trustees of the hospital have to set aside a budget to litigate this all the way to the Supreme Court in Frankfurt. Is that where it sits? I've been learning some Kentucky geography the last week or so. All I know is that Kentucky's in the United States of America, so what am I doing here? So that's how you, in other words, policies that are inert are actually, they breed cynicism, and that can injure professional integrity and the kind of organizational culture that should support it. So you need to maybe get together with like-minded colleagues, check with the administration, say, if we follow this, are you with us? And if they say, of course, then you need some people who are willing to step forward and take the heat. But the second the administration were to desert you, that's a failure of co-fiduciary responsibility. They've got to have their feet held to the fire.
And Mark?
One comment and one question. I think the comment surrounds futility policy, and that is the problem in defining what is futile treatment. And, I think it's easier to agree in the abstract that you support futility, but everyone has their own definition of futility, and it seems that if it's going to work, it needs to be some common definition. The question was, in the view of physician as fiduciary, it's a two-party relationship, and yet many of the things that we would call bioethics issues arising from physician-patient relationships are the implications for third parties, for public health, for research, etc. And the question is, how does the viewing the physician as fiduciary shed light on dealing with these other relationships?
The comment was, if you're going to invoke futility, you better be clear what you're talking about. Is that fair? And then the second one is, what's the implications of fiduciary responsibility for areas like research or public health? The first one first. There are 4 concepts of futility in literature, I think, that are conceptually clear and clinically applicable. And you always, so the first question is, what concept are you invoking? Second is, what's your evidence base? Because you can have a clear concept and then wobbly evidence for it, and you shouldn't be using it. The first is very common. Physicians know it. It's physiologic futility, and that is the usual physiologic outcome you aim to achieve has become, no one reliably expects it to occur. And the classic example is you do not prescribe antibiotics for viral infections. And it's also the concept that has been used to stop resuscitation for years. When there's no reasonable expectation of the restoration of spontaneous circulation and respiration, the resuscitation is called. So it's already in common use. The second concept is called variously clinical or overall futility, and it means the patient has irreversibly lost the capacity to interact with the environment and develop as a human being. The paradigm diagnoses, but not the only ones, are permanent vegetative state or persistent vegetative state before it, and severe head trauma resulting in loss of interactive capacity. And there the argument is that medicine is not vitalist. It never has been. Its job is not to maintain life just for its own sake. You can't find that anywhere in the history of medical ethics globally. I'm in the process of finishing the editing of the first global history of medical ethics, 63 chapters from scholars from all over the world, and it's not in any global tradition. Very interesting. Just can't find it. The third is what Brooke Brody, my colleague, and other colleague Amir Halevi have called imminent demise futility. You expect death to occur in the current admission, and the patient will not recover any interactive capacity before that. That's very important. And you can stop treatment there. Those are all clinical judgments from the physician's perspective. There's one patient-centered concept called qualitative futility, and this Tom Tomlinson and Howard Brody put in the literature in their argument, papers in futility way back in the early 90s in JAMA New England Journal, where the patient's current quality of life or projected quality of life is unacceptable to the patient. To use that concept, you have to have a reliable account of the patient's values and preferences, what the patient did and found value in, and it's got to be patient-based, which means it will only work with adolescents and older. You can't use it with younger children. And it's patient-based, because there are studies showing that when you ask physicians and nurses to rate the quality of life of the severely disabled and compare their ratings with the self-ratings of those patients, the professional folks come in way under. So this is not a professional judgment. This has to be based on the patient's perspective, rigorously reconstructed. So when futility is invoked, and I'm the ethics consultant, we've trained our ethics consultants at St. Luke's, they pull out the sheet, said, here it is, we have a workup. And they go right through these and figure out which concept are you invoking, what's the evidence base, is it sturdy? If it is, then we go forward. If it's not, we don't. We had one case where the nurses thought that it was futile, the patient's management of liver disease, they thought that the medication wasn't working, and the attending said, what? Of course it is. Let me show you. And the nurses hadn't looked at some recent lab values. These things happen. I mean, I never make such a mistake, but I'm always shocked and interested when someone else does. So that would be now, the extension of the concept of fiduciary responsibility. Amy McGuire is a new member of our faculty, an attorney, and just got her PhD in medical humanities from Galveston. She's developing the idea that investigators should think of themselves as having fiduciary responsibility for subjects, certainly in clinical research. And what's interesting was I came across a passage in the Gray Book, Beecham and Childress 5th edition, where they say that the informed consent duties of investigators are governed by fiduciary responsibility. And I think that comes from Tom's work on the history and theory of informed consent. So that seems to me to be right, that clinicians don't cease being fiduciary just because they're running a study. They continue to be fiduciaries. My understanding of community medicine and community health and public health is they think of the community as their patient. So that's the language of fiduciary responsibility. It's just now writ for a population at large. Now you've got to be careful because community and public health intersect with non-health related matters. For example, when you're doing assessment of elders for self-neglect and they are not bathed and smell, right? Well, that's a socially unacceptable habit, right? Unless you're my students in the old days when I was at A&M and they're just back from the hog station coming to philosophy class. But the advantage was your sinuses were completely clear by the end of 80 minutes with students who are just back from the hog or the swine station, even better. By the way, that site is now where the presidential library of George H.W. Bush now sits. Is that a delicious irony or what? Right? Texas is a great state. We don't fool around. So I think so you've got to be very careful. Now, self-neglect that results in a hospitalization that you can then show was caused by, among other factors, lack of self-hygiene, then you're on stronger ground. So I think you can invoke fiduciary responsibility, but as you're at the borders of other social nexuses of values, you've got to be very careful to keep your intellectual authority well-bounded so that you don't assert authority where you don't have it. So I think, and certainly when I teach courses in management for the College of Physician Executives, and I've taught now many thousands of physician leaders, I say to them, you and your lay colleagues who run your organizations are co-fiduciaries with your clinical colleagues for the entire population of patients that your organization has assumed responsibility for. And they think this works. I mean, I think it has very broad applicability. And it's where bioethics does, since it doesn't have the concept, and indeed is suspicious of it, again, leaves clinicians and organizations, I think, much weaker intellectually and practically.
Eric, you got a question?
I wanted to know if you could comment on this following scenario dealing with your core content bioethics. In the state of Kentucky, you cannot do an HIV test on an individual unless they have signed consent, unless they are in a unit which is terminal event, unless you make a correct diagnosis. However, local hospitals have gotten around this where a patient enters the hospital system for mammogram or any other kind of procedure, and all the documentation that they sign, there's a signature statement that says if a hospital employee has an occupational exposure to your blood or body products, we can do an HIV test on it. At the time that you're signing your insurance papers, this little highlight. I think several hospitals have that. I don't want to tell you which side I'm on because I'm ambivalent at this point. I do a lot of HIV work and I have a public health sense and I want to protect the hospital staff. But on the other hand, considering this, have we put our needs above that of the patient by saying you have to have an HIV test under these circumstances in our hospital?
So the question is, you have a restrictive law here about the ability to get HIV tests without consent, but you have a hospital policy says that in the case of a documented occupational exposure, the test can be performed.
And the patient signs this at the entrance.
Right. Right. The ethical justification that is just straightforward is it's a standard limit on my autonomy that if I'm about to cause impermissible, unconsented to harm to an innocent other, my autonomy collapses. I think that's a well understood. I mean, even Mill, the great advocate of liberty, would accept that as a boundary condition. So it's easy to justify it. You have to remember, history is really important. HIV started out in a politically marginalized group, namely homosexuals, that was well into the process of their civil rights movement. Right, the Stonewall riots and all had occurred about 5-6 years before HIV was first described. So it was in a group that was in a civil rights movement and was not going to be turned back by anything. And that's why the civil rights language got used. And then, of course, you have to remember, physicians acted very badly in response to it. I mean, you had psychiatrists double gowning and gloving to do psychiatric histories on patients with HIV. I'm not making that up. That happened. In my neighborhood school in Virginia, my wife and I don't have kids, but this was a big brouhaha. There was a 4th grader in the late 80s who had HIV, already one of the first vertical transmissions showing up. And the doctors in the neighborhood said their kids weren't going to be allowed to attend, who were 4th graders, weren't going to go to school. So where's the leadership? So the public said, well, geez, if the doctors are scared, we're really scared. And besides, these people are weird. They're gay, right? So they're bad. Now, thinking, how did a kid get it? Well, obviously, mother's fooling around, so she deserved it. Remember, these concepts that people deserve their bad diseases, right? We saw major religious leaders saying the same thing about the tsunami. You people have sinned a lot. God's angry. He sent this wave. Should have been acting better. These are very old, ancient ways of thinking. HIV has been transformed from a uniformly lethal disease to a disease we can turn into a chronic condition with which people can live with a high functional status and quality of life for a long time. Not letting us test you against your will to see if we can get diagnostic information that would help you. With all the civil rights protections now in place, especially under the Americans with Disabilities Act and the federal courts that have interpreted that to protect patients with this diagnosis, your state policy here is, I'll use a technical philosophical term known only to my colleague, it is nutty. And so the medical community needs to go to the legislature and say this policy made sense then, when we were in a civil rights model, when there were serious social consequences, before the protections were put in place. Now they are. We need to be able to aggressively go after this information if we think a patient is at risk for HIV transmission, because patients need to know this. Because the public still thinks it's a lethal disease. The public understanding is still behind the medical reality.
If there's potential transmission that has occurred, and you're wanting to go ahead and gain access to the blood to protect that innocent...
It's a no-brainer.
No, I don't disagree with you. As a matter of fact, this was part of the statutes up in Michigan where I was in practice for 10 years. But the question is, what if the patient were to say, I don't want to know the results? We can take the blood. I remember signing the form. We can find out if Bob over here got exposed. But just don't tell me the results.
Yeah, I mean, Rosamond Rhodes has published a nice piece in the Journal of Medicine and Philosophy in the clinical ethics issue that I edit each year on genetic testing and whether there's a right not to know, and does a beautiful job of demolishing it. Because the central information about you when it has immediate implications for other people in your life whom you could injure by withholding the information is your primary relationship to them is not one of rights, it's one of obligation. So it's a misconstrual of the relationship. So you may be obliged to learn and share your genetic condition with your genetic kinfolk and maybe even your spouse, right? Or maybe obliged not to, right? I got a very good friend who's given his family history of Alzheimer's, would like to get the ApoE test. His wife says the following, which he thinks is exactly accurate. You're a hell of a worrywart. If you test positive, you're going to become an impossible man to live with. And on most good days, you're already pretty challenging in this department. I don't want the burden. Now, in our standard bioethics model of consent, he could ignore that. On an enriched model that we're now dealing with groups, families, genetic kinfolk, the whole idea of one-on-one dyadic consent just is totally inadequate. We need to rethink that. and begin to think, gee, the fundamental relationship within families is one of obligations, not rights. Any rights, for example, parents have over their children are derivative of their fulfilling their duties. They don't start with rights, they start with duties, and then rights derive from that. And because the relationship of, in other words, is it the case that I might have fiduciary responsibilities to my genetic kinfolk? I think the answer probably is yes.
So you wouldn't have too much trouble with Bill May's work on the physician's covenant or mine on the family covenant?
Covenanting relationships, I think, in Bill May and your work probably should be regarded as probably no different from fiduciary relationships. So we probably ought to, the nomenclature maybe have to be changed to the right nomenclature to get the concept clear. Yes, sir. Here comes the question on Leibniz. Get ready, everybody. Now it gets really exciting.
It's about the universal harmony.
Excellent.
On page 8, I'm trying to understand your basic claim against these people like Beach that you're criticizing. And I've sort of narrowed it down to page 8, 3B of your handout. I think if that's central to your opposition to those Beach-like people, right? You're basically claiming that the physician should use their competence primarily to protect and promote the health-related interest of patients, keeping the physician's own self-interest in a systematically second position in life. But I take it that overall your argument is that with professional activity substituted for beneficence or even paternalism, then the physician has a far larger role to play in the entire decision-making process than people like Beach would have us believe, where the physician has virtually no role to play except that of providing information that the patient then uses to make his or her own independent decision.
The question is, where do I disagree with people like Veach in the contemporary bioethics account, especially on the physician's role as a fiduciary in the decision-making process? And the question really is there a much larger role than the bioethics role as conceives it? And the answer is yes. Veach treats physicians as sources of technically reliable information, but no judgment about the application of that information to anyone's best interest. I think he really is a postmodern thinker. He rejects the notion there's any privileged perspective on anything, because I think he's got a postmodern view of science.
But he's like a lot of other people who probably don't have a postmodern view of science.
I think that postmodern views are more implicit in contemporary bioethics than a lot of contemporary bioethicists are aware of. The great virtue of Veach is he's right out front about it. Bob knows how to lay out an argument, and so that's what he does. So you're right, there's a much different role. As I said, what's interesting is in the court cases on informed consent, they couched it as fiduciary responsibility, the informed consent cases, from the beginning, that it's the physician's duty to identify the medically reasonable alternatives. That's what protects the patient from the paternalistic failure to give a reasonable option, not to give all the options. In other words, the court saw that one way I can restrict your autonomy is to unjustifiably constrain your options. Veach's answer is to give them all, technically. My answer is no, give all the medically reasonable ones.
Okay, so that's your answer to the question of why aren't you simply affirming paternalism all over again? Is that paternalism does not exist whenever the physician is giving all the medically reasonable alternatives.
That's correct, and if the patient elects any one of them, then professional integrity is not violated. Now, if the patient rejects treatment altogether and wants to act so-called against medical advice, if the patient wants to cease being a patient, there's nothing in fiduciary responsibility, I think, that can give the physician the justification to say, no, you have to stay my patient. But what if the patient wants to stay a patient, but wants to engage in a course of management that violates professional integrity? Then I think we've got a problem. And so the ethics of refusal in bioethics fails to see a problem. It emerges most dramatically in the case of futile treatment. But at our VA, we have patients who shouldn't be leaving the hospital, and they want to. And our residents go through all kinds of, how do they politely put it, delaying tactics. Now, it's gotten harder since the VA has an electronic record, because the old delaying tactic was, oh, we can't find your record, which was frequently a true statement, so they didn't have to lie. But that doesn't work anymore. But they can say, we need to get a social work consultant, she's not available till this afternoon, which actually might be true. And it's a delaying tactic to try to persuade the patient to reconsider.
Mary?
When you say that we have many patients who shouldn't be leaving the hospital, What criteria are you using when you say that statement?
Oh, a reliable prediction that their health status is such that on discharge they are going to decompensate rapidly and come back in sicker with a lower baseline and a worse prognosis. And so they are jeopardizing their own health.
But does it take into consideration their mental status?
Does it take into consideration their mental status? Yes.
Because, I mean...
Sure, they could be autonomously...
I think that's a difficult question to answer for us. I mean, it's easy for us to say physically they might go downhill. It's like making a decision about whether someone should go in a nursing home. Yeah, they can't take care of themselves at home. But some people, as soon as they get into a nursing home, deteriorate because they're emotionally so distressed that even if their physical stuff could get better, they don't do well.
Right.
I mean, I think it's hard to judge that.
It is. I mean, the question is, how do you judge what you think is an inappropriate discharge plan by the patient who's fully competent?
Well, how do you judge what's in the best interest of the patient? That's the question.
If you have reliable evidence that they're going back to their home setting, which could be very fragile and chaotic, is going to result in their getting sick again faster, and we know what happens. Their baseline goes down, drops. They're over. But what happens is when your baseline drops and the declivity of your chronic disease steepens, you put not only your health at stake, you put your future autonomy at stake because your functional status is greatly impaired.
Is it not your choice to decide? Is it not my choice to say I'd rather be at home and know my physical ability is going to decline rather than put my freedom in choice?
That's the standard argument, and here's why we ought to reconsider it. Because it's not just a threat to professional integrity. In a system like the VA, you are about to unnecessarily expend resources you do not own. See, the bioethics of refusal never looked at the economic consequences to the provider systems of the refusal. If they thought it was cost-free, that's just false in systems like the VA.
What if it's not? What if it's not cost? Maybe they are not going to. I mean, if the patient says, "I understand this, and I'm not going to come back and ask you to spend lots of dollars on it,"
then we could say two things. Your decision from a point of view of your health is unwise, and from the point of view of justice is impermissible, so we're not bound to respect your refusal. Now, what may you then do becomes an interesting question. Can you force the patient? These have to be thought through. But the notion that refusal is the end of it. See, here's my worry, at least among our residents at the VA in medicine, they want to discharge these patients. Why? They're too much work and they're a pain in the butt. That's abandonment. That's unprofessional behavior. So there's where, again, bioethics says they have a right to refuse, they're competent, and by the way, if that's in my interest and my convenience, and that becomes my primary motivation, now I'm flying a false flag of autonomy. That's very worrisome. That corrodes an organization's culture, in this case, the organization of a residency.
Actually, sometimes it takes more work to keep somebody out of a place than it does to put them in a place. I mean, as a physician who's had to fight for a patient, for example, his family wants to put him in a home, and they want to stay at home.
Well, see, on the geropsych service at the VA, where the issue comes up is not whether they go to a nursing home, is they cannot go back to the unstructured, unsupervised living alone where they are. They need to be in a structured setting. Now, what can we get them short of a nursing home becomes the question. Because there is some evidence for some populations of patients, nursing home admissions actually shortens their lives. You don't want to do that. But getting them into a group home, where there's going to be some supervision and observed medications, that's a constraint on autonomy that may be worth vigorously negotiating with these old coots who even then don't want to do it.
To me, the question still is more not so much. I think financial is important. I don't mean that, but it seems to me that oftentimes the question is really not what's. I mean, the question is what's best for the best for the patient and the society, and what's best. And I think financial is only one small piece of it. Oftentimes, it's driven by what's best for me.
No, you see, you don't ask what's best for the patient. You ask what is in the health-related interest of the patient, because that's all clinicians can speak to.
That's not right. Is that right?
Sure.
You mean I can't, as a physician, speak to
what's overall best for me? No, that's my business.
But I mean, if they're telling me if I'm saying the health-related benefits are this, but they're telling me, you know what, that may be the health-related benefits, but I have other benefits that are more important to me, and I don't listen to that.
Then you say you're jeopardizing your health and you're jeopardizing your own autonomy, and you're therefore jeopardizing those things you've told us you value. Your decision is imprudent. Reconsider it. That's all I'm arguing for. Then there's the justice-based consideration that in a system like the VA, if you have an unnecessary readmission, you're using up resources that could have been saved. And the VA is under tremendous financial stress. It hasn't had anything other than just barely covered for inflation for years. And when you've got formulary costs still rising at 10 and 12% a year, right, which they are in the VA like the rest of the United States, these are really serious matters. My freedom to refuse and then sop up resources that I could prevent sopping up, most theories of justice would say, wait a minute, we can put a constraint on you. Now, what constraint? See, my point is the bioethics paradigm doesn't ask the question. Autonomous refusal ends the story. Right. So the analysis is incomplete. It leaves out professional integrity, it leaves out the effect on the patient's health, it leaves out the effect on the patient's future autonomy, and it leaves out legitimate justice-based considerations of constrained provider systems like the VA or public hospitals, or insurance plans that are really struggling to maintain themselves as financially viable on behalf of, like, employers who self-insure. I mean, I'll give you an example. Baylor 6 years ago ran a $500,000 deficit in its health self-insurance plan. So it laid off 50 non-faculty employees the next day. Now, that $500,000, I can assure you, was from inappropriate overuse of resources by pampered Baylor faculty. And 50 secretaries lost their jobs. Where is it written that I can exercise my autonomy with that kind of social and economic injury? I mean, even a mill would get a little nervous about that. That's what in other words, you start thinking systemically, which justice requires you to do, the autonomy-based paradigm of contemporary bioethics. Now, I'll grant you Beecham and Childress are not autonomy-based. They are much more nuanced. They actually defend paternalism in the latest version of the volume. So I don't want to label them with this. But someone like a Bob Veach and the standard popular account of principalism and bioethics, autonomy is always the trump. That's just, there's a moral price to be paid.
Any other questions? Thank you very much.
Thanks, y'all.